lymphomas, so Hodgkin's and non-Hodgkin's lymphomas, talking about the differences between them and the subtypes of these different disorders. Okay, so before we begin, we'll be this is what we'll be looking at. Leukemia. I will first start with the difference between leukemia and lymphomas. Then we'll narrow down to lymphomas. Start with Hodgkin lymphomas, as you can see here. Then next, move on to non-Hodgkin lymphomas, and then that will be all for today. And after that, when I get to the end, you can ask your questions, right? You can ask the question, whatever questions you have, you can ask them. And then after the questions, we'll now go to the platform to answer questions on the quizzes platform. Okay, so before I begin, I want to give you an overview. So when they talk of leukemias or lymphomas, they're actually talking of malignancies or cancers that arise from white blood cells, right? White blood cells. So, but when you talk of lymphomas, you're actually talking of tumors from lymphocytes, particularly B and T cells. Lymphocytes, that's B and T cells. So for those who attended the immunology sessions, we discussed what the B and T cells are, what part of the immune system they belong to. All right. So when you talk of lymphoma, you're talking of the B and T cells. All right. So, and majority of lymphomas arise from your B cells. Majority of the lymphomas, whether you're talking of Hodgkin's or non-Hodgkin's, majority of them arise from the B cells, right? So, when most the B cells are the ones that are primarily involved in lymphomas, whether that is you're talking of Hodgkin's or non-Hodgkin's, and then for Hodgkin's, when you talk about Hodgkin's, it's a disease, it's a specific disease entity. So a Hodgkin disease or lymphoma is a diagnosis of its own. It's just that when under it, there's just a specific variants of Hodgkin's lymphoma. But Hodgkin's lymphoma is a disease on its own, which you can make a diagnosis of that. But when you come to non-Hodgkin's lymphoma, okay, when you come to non-Hodgkin lymphoma, there are several uh, disease entities under it, specific disease entities, and each of these have different presentations, different molecular abnormalities, chromosomal abnormalities. So you can't just stop at Hodgkin's lymphoma and go home. You have to still give a specific diagnosis under non-Hodgkin's, all right, under non-Hodgkin's, which we will look at. So there are several disease entities of that. So, and this non-Hodgkin's involve both B and T cells. Why Hodgkin lymphoma is primarily B cells, right? Primarily B cells. Why non-Hodgkin's, most of them B cells, and then a few of them T cells. All right. So that's the brief overview. Then we'll look at the difference between the two of them shortly. So when we talk about leukemias and lymphoma, what's the difference between them? So when you talk of leukemias and lymphoma, what are the differences? Okay, so when you say leukemias, talk about leukemias, they are typical malignancies that arise from the bone marrow, right? From the bone marrow. So, and it also involves other types of white blood cells, mostly granulocytes, right? So, as I said, it could be lymphoid and myeloid. So you have the acute lymphoblastic leukemia, or for example, then the AML, acute myeloid leukemia. So it can be both of them, both lymphocytes and granulocytes. Both lymphocytes, granulocytes are both the B T cells and the granulocytes. Meanwhile, for lymphomas, it's mostly the B and T cells, the B and T cells, the lymphocytes. And the other thing about leukemias is they involve the bone marrow and then they spill out, these malignant cells will spill out into the bloodstream. Okay. They involve so they arise from the bone marrow, they arise from the bone marrow and then spill out into the bloodstream. And then from the bloodstream, they can move and involve other organs secondarily. So primarily from the bone marrow, spill out into the blood and spread out everywhere. That's why if you do a peripheral blood film, you would see them. So and this is important because when you get when we talk about other conditions in hematology, particularly for leukemias in the future, though some questions in your U world or all of that, they will give you blood films talking about, okay, if you see this type of abnormal white blood cells, what should you be thinking? Is it, are you thinking of uh, are you thinking of more of myeloid leukemias or lymphoid leukemias? So though they can give you blood films like that showing those abnormal white blood cells, and then you have to now differentiate based on how they look in the peripheral blood. Okay, so they can give you that peripheral film, can give you a CBC count, okay, showing you elevated white blood cell count, low white cell count. Okay, so when you talk of lymphomas, when you talk of lymphomas, they are typically arise from the lymph nodes and then and involve other secondary lymphoid organs such as the spleen, for example, and then other tonsils, adenoid, Peyer's patches in the GI. So they involve but primarily arise from the lymph nodes and then can spread from that lymph node to other lymph node groups or to other lymphoid organs. Okay, so that's the primary difference. So lymphomas, mostly lymphocytes, leukemias can be both of them, lymphocytes and granulocytes. And then leukemias involve the bone marrow and then spill out into the blood. Lymphomas, mostly lymph nodes, and then spread to other lymphoid organs. Okay, so now that we finished the differences between the two of them, now narrowing down to lymphomas. So when you talk about lymphomas, there are two main categories, two main broad groups. There's the Hodgkins, all right, and the non-Hodgkins. Hodgkins and non-Hodgkins. Now, the name Hodgkins actually comes from the person who discovered it. His name is Hodgkins, discovered in the late 19th century, but it wasn't recognized as a specific disease entity until the 1960s when they found a specific type of abnormal tumor cell. We'll talk about it in shortly. So it wasn't until shortly in the last 40, 50 years that we now recognize that, okay, Hodgkin is a specific disease entity. And then people now started coming up with, okay, other disease entities that were similar to the Hodgkin's but different. So they put those ones together as non-Hodgkin's, right? So what's the difference between the two of them? They both, now the thing both of them share is systemic symptoms, where you talk of the fever, night sweats, and weight loss. Fever, night sweat, weight loss. So for those of you doing microbiology, you'll notice that these things look similar to TB. Okay, they will seem similar to TB, but it's different. It's not the same as TB, as we'll see shortly. So TB too can have all this low-grade fever, night sweats, weight loss, lymphadenopathy as well. But TB presentation, there's some caveats to that will point you to TB instead of Hodgkin's or non-Hodgkin's lymphoma, as we'll see. So when you now look at Hodgkin's lymphoma, Hodgkin lymphoma. Sorry, please mute your mic as well. Can you please everyone mute your mic so that you don't disrupt the flow of the class or interrupt while I'm giving a presentation. So for Hodgkin lymphoma, they are typically localized to a group of nodes and spread from those group of nodes to other groups. So they can start from the cervical in the neck, spread to the axillary in the armpits, and then go from there to the mediastinal, for example. So they start there, spread to specific lymph node groups. So the cervical to the axillary to the mediastinal, and that's very important. Okay, so you typically see we talk about the patients who presents to you has lymph node groups in the neck swollen, and then after some time you notice the ones in the axilla are also involved. Then maybe after some time you do chest X-ray, you see the hilar lymph nodes are involved as well. Okay, and so the staging. is the strongest predictor of prognosis. So when we talk about prognosis, that's the survival of the patient. And compared to non-Hodgkin lymphoma, it has a better prognosis, right? And so that was the difference with non-Hodgkins. Non-Hodgkins now tend to involve multiple lymph node groups, and extranodal involvement is common. So when you say extranodal, that is outside the lymph node, outside the lymph node. All right. So when you're talking of that means it can move to the liver, to the spleen, to the brain, to other organs, and it doesn't spread from one lymph node group to the other. So it doesn't have a predictable pattern of spread. And because of that, because it can spread outside the lymph node and involve other organs, its prognosis is worse than Hodgkin's lymphoma. So part and the other thing is about the extranodal spread. Part of the now this the I said earlier that Hodgkin tends to go from lymph node group to other lymph node group, but one of a particular group of lymph nodes that or set of lymphoid tissue that Hodgkin lymphoma does not involve are the you talk of the mesenteric lymph nodes. So mesenteric lymph nodes that are in the GI, they're the ones that drain the GI tract. Okay, mesenteric lymph node and we call them the Waldea ring. Okay, Waldea ring. So if you see this image here, so look at this. That's the lymph node tissue in the neck that drain the pharynx, the oral pharynx, and the the nasopharynx. So this group of tonsils in the oral pharynx, nasopharynx. So Hodgkin lymphoma doesn't involve this, and also does not involve the mesenteric lymph node. But non-Hodgkin's can involve this group of lymph nodes. Okay, so that's one difference you need to remember. However, the most important difference between Hodgkin and non-Hodgkin is the presence of Reed-Sternberg cell. All right. The most important difference between Hodgkin and non-Hodgkin is the presence of Reed-Sternberg cell. If you see Reed-Sternberg cell, it's Hodgkin until proven otherwise. If you don't see it, non-Hodgkin's. All right. If you see Reed-Sternberg cell, we'll describe it shortly. So Reed-Sternberg cell is the main thing that differentiates Hodgkin from non-Hodgkin's. It's the main thing. And this cell is extremely important for you to know. I'll show you images of it because they will give you images of this in the exam and tell you the patient came with a lymph node and they saw this cell in that lymph node. What's the diagnosis? Once you see it, it's Hodgkin. If you don't see it, for non-Hodgkins, they probably won't give you slides, images of the tumor. They will probably most likely describe it and then ask you the diagnosis. But for Hodgkins, they can give you the image of that with Stenberg cell, right? And this is what it looks like. We'll describe it shortly, right? What it looks like. So once you see it, you're talking of Hodgkins. If you don't see it, then and you're talking something else, maybe think of non-Hodgkins or other diagnosis. Okay, so as I mentioned earlier, whether you're talking of Hodgkin or non-Hodgkin, most of them tend to involve the B cells, and rarely T cells, right? Non-Hodgkin's doesn't even involve T cell, but I mean, Hodgkin doesn't involve T cells, mostly B cell. But non-Hodgkin can involve both B and T cell, but majority of non-Hodgkin's is of B cell origin. Okay, and then for when we come to non-Hodgkin's, it has a bimodal distribution, meaning that it involves two groups of patients separated by ages. So you have the young adults first, and then those over the age of 55. And then in non-Hodgkin's, you can involve both children and adults. Although this distinction, it's not hard and fast, so it's not something you should uh, uh, hold fire onto rigidly because there are differences. They are not hard and fast. All right. So for the oncogenic viruses, so when I say oncogenic viruses, I'm talking about microbes or oncogenic microbes. I'm talking about microbes that can cause associated with cancers. oncogenic microbes. So when I say oncogenic microbes, I'm talking about infectious pathogens. Okay, oncogenic microbes. I'm talking about infectious pathogens that can cause cancer. All right, pathogens that are associated with cancer. So we did for the part. This was we covered something like this in our pathology sessions. So for Hodgkin's lymphoma, Epstein-Barr virus. Now, this Epstein-Barr virus, because we said it's B cell, whether you're talking of Hodgkin or Hodgkin lymphoma, we said these viruses can attack B cells using a specific receptor. It's very important you know that receptor. We discussed this also in our immunology sessions. If you remember when we talked of the cell surface markers of B cell, B cells are recognized by a certain marker. We call them CD, whether B or T cell. They call them CDs. And those, the full meaning of CD means cluster of differentiation. All right. And those CDs are important, one, for identifying the type of lymphocyte you're talking about, whether you're talking about B cell, T cell, macrophage, hemopoietic stem cell, or whatever. And then the other thing is some pathogens can use these CD molecules to infect the whether whether a B cell or T cell, macrophage, or and so on. So it's very important for you to know those specific markers. And for B cell particularly, okay, we said it's identified by CD19, 20, 21. There are more of them, but for step one, this is the ones they mentioned, 19, 20, and then has some immunoglobulin M and D on the surface. All right. And now, when you're talking of Epstein-Barr virus here, okay, when you're talking of Epstein-Barr virus, the most important one it uses is CD21. CD21, that's the one it will use to infect the B cell and cause it to transform into an abnormal cell. All right. Okay. So, so for Hodgkin lymphoma, Epstein-Barr virus, very important oncogenic virus. Now, when you talk of non-Hodgkin's, there are several other types of viruses too. HIV, Epstein-Barr virus, human T cell lymphotrophic virus. Okay. And then also autoimmune disorders. So we looked at autoimmune disorders in immunology as well. Some of those autoimmune disorders, when you're talking of uh, Sjogren's syndrome, you're talking of Hashimoto thyroiditis, for example. These autoimmune disorders are associated with non-Hodgkin's lymphoma. If they go on for a long period of time, they can lead to the non-Hodgkin lymphoma arising in the organs that are involved with these autoimmune disorders. Okay, so that's the difference between Hodgkin and non-Hodgkin. So like I said, the most important difference between Hodgkin and non-Hodgkin that I want you to get is Rich-Steinberg cell. That's the one that is found in Hodgkin's, but not non-Hodgkin's lymphoma. The other thing is most of the primary cell immune white cell or white blood cell that is involved in whether Hodgkin or non-Hodgkin is a B cell. All right, the B cell. So, and the other thing about that I want you to pick is there are certain oncogenic viruses or pathogens that are affected that are involved in Hodgkin or non-Hodgkin's lymphoma. For Hodgkin's, Epstein-Barr virus. All right. For non-Hodgkin's, you have HIV, Epstein-Barr, human T cell lymphotrophic virus. There are other pathogens here. These are not all. There are still more pathogens. We'll get to that when we come to non-Hodgkin's and autoimmune disorders for non-Hodgkin's as well. Okay, so now moving on to Hodgkin lymphoma. Okay, so I said the characteristic feature of or the diagnostic feature of non-Hodgkin lymphoma is the presence of Rich-Steinberg cell. All right, the presence of Rich-Steinberg cell. And look at it. It's a giant cell. So what do you mean by a giant cell? A giant cell is a big cell. It's a giant cell. It's a cell that's bigger than every other cell. As you can see here, look at it. And then all these other cells, smaller cells are around it. Okay, let's look at another image of it here. So this is another picture of that. All right, so it's very important for you to get this image and remember it because you can get images of this in the exam. You can put this, say a patient came, peripheral lymphadenopathy, painless, with systemic symptom, fever, night sweat, weight loss, and then biopsy of the lymph node, they'll give you this image. So you need to know that this, they're talking about, once you see this, all eyes, this presence of these two nuclei together. So it's a giant cell. You can see this is the whole outline of the cell. Okay. You can see this is another cell here. This is another cell. These are different smaller cells. All right. So you can see it's way bigger than every other cell. That's why they call it a giant cell. Then these are the nuclei. This is one nuclei. This is another nuclei. And then this is the nucleolus inside it. So it's binucleated, two nuclei. So, and then they describe this as all eye. Okay. All eye appearance. So the eyes of an owl. Right. So very important for you to remember this image. Okay. So going back, that's say it's a giant cell, Ritz-Stenberg cell. So Ritz-Stenberg cell is the characteristic feature of Hodgkin's lymphoma, bilobe nucleus. All right, like a nucleus in two nucleus or nuclei with the nucleolus inside. So that's why they call it the all eye appearance. And then there, how do you identify this Ritz-Stenberg cell? The CD15, CD30. CD15, CD30. All right. So you can see first aid highlighted them in red. So it's very important you remember that too. So what are the features of Ritz-Stenberg cell? Number one is a giant cell. Number two, it has two nuclei, right? Two nuclei that give the all eye appearance. Number three, it has two specific markers, CD15, CD30. Then number four is of B cell origin, right? So CD15, CD30, binucleated, giant cell, uh, bilobe nucleus. Now, that's the specific subtypes of it or variants of the Hodgkin's. And you don't need to know them in much detail. Just need to know that there are four of them, right? One, two, three, four. And the most common is the nodular sclerosis. They'll all have the same presentation where you have painless peripheral lymphadenopathy in a young person with with fever, night sweats, weight loss. You have the Ritz-Stenberg cell in all of them. Okay, so you just need to know, okay, there are four variants. The most common is nodular sclerosis, right? And then the one with the worst prognosis, lymphocyte depleted, okay, which has the worst prognosis. And then the one with the best prognosis is lymphocyte rich, right? And then mixed cellularity has a eosinophilia associated with it. Although when you look at the lymph node in this patient, you'll see there'll not just be lymphocytes, there'll be all kinds of cells, the white blood cells that will come in there inside that lymph node. That's why the lymph node is big, because the Ritz-Stenberg cell, it's a B cell, but and what it does, it secretes cytokines and which attracts a lot of white blood cells that come into that lymph node, and that's what causes the lymph node hyperplasia, right? Or causes the lymph node enlargement, lymphadenopathy. Okay, so you need to know that the most common is nodular sclerosis, the one with the least worst prognosis, lymphocyte depleted, one with the best prognosis, lymphocyte rich, right? So as I was talking earlier, this Ritz-Stenberg cell is a B cell. It secretes cytokines. If you remember, the transcription factor that is involved in that is nuclear factor kappa B. So that transcription factor is activated constantly in this B cell, and then which leads it to secrete a lot of cytokines. And those cytokines now will attract white blood cells into the lymph node, and then that's what makes the lymph node swell up big. So, and then if you remember, this B cell is actually a germinal center B cell. So it's located in germinal center. Remember, if we talked when we talked about our lymph node structure in immunology, we said the lymph node made up of two parts. You have the cortex and the medulla, and then within the medullary sinus, and then within the cortex you have the paracortex and then the lymphoid follicles. Right. So the B cells are located in the lymphoid follicles, and then within the lymphoid follicles you have the primary and secondary follicles. Okay, so that's mostly for the Hodgkin lymphoma, right? So moving on from Hodgkin lymphoma to non-Hodgkin's. So when we said the non-Hodgkin can involve both B and T cell, but most of them involve the B cells. Okay, most of the non-Hodgkin lymphomas involve the B cell, and then a few of them, for the purpose of step one, also involve the T cell. Now, this T cell, the T cell that I'm talking of here is particularly the CD4 positive T cell, also known as the helper cell. Okay, CD4 positive T cell. Remember when we studied in immunology, there are two main types of T cell. There's the cytotoxic T cell, CD8 or CD8 positive T cell, and then the CD4 positive or helper T cell. So non-Hodgkin lymphoma typically involves the helper T cell, that's the CD4 positive T cell. All right. And then for the B cell, we said most of these B cells will also be the germinal center B cells. Okay. Germinal center B cells. Okay. So for the B cell, the subtypes, the different types of the non-Hodgkin, there are six of them you need to know for the ones that are involved B cell. Okay. Six of them. Six of them that are involved. Now, the most common non-Hodgkin lymphoma involving the B cell is the diffuse large B cell lymphoma, right? The diffuse large B cell lymphoma. So here it says the most common type, as you're saying. But in addition to that, and it typically occurs in older adults, as we've seen, as you've shown here, mostly in adults, particularly older adults. But the other thing you need to know about diffuse large B cells, it also involves arises in situations of immunosuppression. Okay, immunosuppression. It typically arises in the setting of immunosuppression. Immunosuppression. So you could get a case of, okay, I see a case of maybe a patient that has a transplant and then he's taking immunosuppressions, and then next thing he starts having lymph nodes are swelling, or the secondary lymphoid organs start to get larger or increase in size, and then they take a biopsy of that, those involved lymph nodes, and then they show you sheets of uh, abnormal cells. But when you see a history of immunosuppression with enlarged lymph nodes and all of that, whether you're talking of HIV, a person with a transplant, okay, so HIV transplants patients, okay, with enlarged lymph nodes or lymphoid organs, and is rapidly growing, start suspecting diffuse large B cell lymphoma. Diffuse large B cell. So it's the most common type of uh, the most common type of non-Hodgkin lymphomas involving B cell, right? And other viral infections like even Epstein-Barr virus can be involved here, right? Epstein-Barr virus can also be involved here, but most in the setting of HIV patients that are taking transplant, all right? And so, what is the genetic aberration? Another very important point: a genetic aberration, BCL2 and BCL6. Now, BCL2, if you remember, we talked about it. Okay, for those who attended pathology class, we talked about it in proto-oncogenes and oncogenes. All right, that's proto-oncogenes and tumor suppressor genes. So BCL2 is actually an oncogene, right? So when we say proto-oncogenes, stroke oncogenes. So these are genes that drive cell proliferation, that drive the cell to proliferate. Now, BCL2, when we specifically is involved in regulating apoptosis, cell death by apoptosis. That's where you hear about BCL2. And BCL2, when we talked about it in apoptosis, we said it's one of the factors that is an anti-apoptotic protein, right? Especially when you're especially when you're talking about the intrinsic pathway. Especially when you're talking about the intrinsic pathway. Remember when you talk about apoptosis, there's the intrinsic, extrinsic, and then the granzyme and perforin pathway. So the BCL2 is involved in that intrinsic pathway that involves the mitochondria, regulating the permeability of the mitochondrial membrane, blocking and when you why is it regulating the permeability of the mitochondrial membrane? Particularly when you're talking of cytochrome C, right? This molecule, which is involved in your biochemistry in electron transport, is that so BCL2 is an anti-apoptotic protein. I'm not going to go into too much detail of that. So when you hear BCL2, it's an anti-apoptotic protein. So if it's an anti-apoptotic protein, it will help the cells survive against or prevent the cells from dying by apoptosis. So that's how the tumor cells survive. So the BCL2 helps them to survive. Okay, and then this BCL6, it's a marker that protein that is involved in germinal center formation. It actually inhibits germinal center formation. So that's why the lymph nodes are involved with diffuse large B cell. You see there's complete distortion of the nodal architecture. You see sheets of abnormal giant large B cells. In fact, the question will tell you when they looked at the biopsy of the lymph node, they saw sheets of large B cells where the nodal architecture is completely gone. So when you see that, you're talking of diffuse large B cell. So, and they have overexpression of these two markers. All right. Okay. So that's so the most important thing I want to get about diffuse large B cell is one, it's the most common type. That's the first thing, the most common type. Number two is common, presents mostly in adults, particularly older adults. Number three, overexpression of BCL2, BCL6. All right. Number four, it typically arises in the setting of immunosuppression, right? Where you're talking about HIV, transplant patients, also with Epstein-Barr, and can involve virtually, and then the fifth one can involve virtually any organ. So you're talking about the the brain, liver, any organ. GIT can involve any organ, virtually any organ. Okay, so that's for diffuse large B cell lymphoma. Now, the next one I'll talk about here is the Burkitt's lymphoma. So, one interesting fact about Burkitt's lymphoma is one of the fastest growing tumors in humans. One of the fastest growing tumors, right? And so it's very aggressive. It grows very quickly, right? And also because of this growth rate, is also and it's also very responsive to chemo as well. So there are several subtypes of it. There's the one that affects Africans. There's the African type. There's the sporadic type, and then there's one that occurs in people with HIV. So typically, what you see is they will give you a history of a young child or maybe in a before puberty or adolescent uh, patient with a jaw mass, okay, a rapidly enlarging jaw mass. So once you see that, the rapidly enlarging jaw mass that is, okay, don't have the pin. So you show you an image of describe a patient with an enlarging jaw mass, and or in the other cases, rapidly enlarging abdomen. So this is within weeks. The mass or the jaw mass or the abdominal mass is growing in within weeks of presentation. So that's jaw mass, particularly the angle of the jaw, right, involving the mandible or abdominal mass that's rapidly growing, and that's one thing. Okay, and then the other thing, they'll do a biopsy of that mass. When you do a biopsy, they'll tell you they saw sheets of lymphocytes, right? Sheets of lymphocytes interspersed with They can talk about apoptotic bodies, interspersed with apoptotic bodies, or distinguishable body macrophages. Now, this starry sky experience, they are not going to give you this description. They're not going to tell you starry sky in the exam. They're just telling you that the sheets, you have sheets of lymphocytes, and then you have uh, so these are the macrophages here. Okay, these are the macrophages, and then you have the sheets, all these dark round spots you're seeing here. So each of these is a lymphocyte. These are the abnormal B cells. Okay, so you can see sheets of them, and then you can see the macrophages, which are the pale pink ones that are interspersed between them, and then this presence of the macrophage in the midst of all this, uh, in the midst of all these lymphocytes, gives rise to that starry sky appearance. So you have the pale macrophages, as you can see here, the pale macrophages here. Got them. Okay, so they are, what are they doing? They are mopping up the dead lymphocytes, eating up the dead lymphocytes, right? Eating up dead lymphocytes, and then you have the abnormal B cells rapidly growing, like sheets of them, and then the macrophage in between them, right? And then that gives you what? This is the starry sky appearance. Okay, so the stars you see are the macrophages, the light pale macrophages, and then the black background, the dark background where the stars are hanging in, are the sheets of macrophages, the sheets of lymphocytes, sorry, that you're seeing. So that's what they talk about, this the starry sky appearance. So each of these stars represent the macrophage, and then each of the black background represents your lymphocytes. Okay, so that's what they mean by the starry sky appearance. So the so that's the thing. So the rapidly enlarging jaw mass, one, or abdominal mass in a young patient, a child or adolescent or young adult, the starry sky appearance, all right? And then the next thing you need to remember about this is the translocation. The translocation that's between chromosome 8 and 14. Chromosomes 8 and 14. So when we say translocation, that's chromosome 8 and 14 will exchange parts, will exchange pieces of themselves. So one takes one piece of one goes to the other, and then the other one piece from the other one comes to the, so pieces of 8 will go to 14, parts of 14 will go to 8. So that's what you mean by chromosomal translocation. And it involves this CMYC. Okay. Very important for you to remember CMYC. And what's this? It's also another proto oncogene. Okay. It's also another protein oncogene that drives cell growth as well. So there's an excellent table in pathology that lists all this stuff, and you can see that all these things are connected. So that CMYC that listed in that table in pathology talks about this. So this is where you find in Burkitt's lymphoma. Very important that you keep that in mind, because it's what is driving these tumors to grow. Then, so as I said earlier here, there's jaw mass that you can see here, jaw mass, particularly in the African type, and then pelvic or abdominal mass in the sporadic form. So like I said, there are three forms. There's the endemic, there's the African type, there's the sporadic type, and then there's one associated with HIV. Okay, so the final thing I'll say about Burkitt's before I move on to the next one is, because it's a rapidly enlarging tumor, all right? When you give chemo for these patients, and I said it's rapidly enlarging, very sensitive to chemo. So when you give chemo to these patients, they they are very prone to tumor lysis syndrome. Tumor lysis syndrome. Okay. So this tumor lysis syndrome can arise even spontaneously in the tumor because it's growing so big. Parts of it will lose access to the blood supply and die off. So the tumor is prone to tumor lysis syndrome, right? Tumor lysis syndrome. So it's a syndrome that occurs in rapidly growing tumors, and when those cells, malignant or cancer cells, die, they release a lot of electrolytes into the bloodstream that can lead to kidney failure, heart failure, and all of that. And there are ways to prevent it, All right, and there are treatments for the. It's an oncologic emergency. It's an oncologic emergency. So when it's something, it's a topic that I'll take with other when I come decide to take the hematology as a subject on its own or as a chapter on its own. But we'll discuss that in more detail. But know that this is one cancer that is very prone to tumor lysis syndrome, where it occurs here. Okay, so and so you need to know about the electrolytes that are involved in it, as well as the treatment for its prevention and all of that. Okay, so that's for Burkitt's lymphoma. We've talked Burkitt's diffuse large B cell. So the next one is um, next one I'll be talking about is follicular lymphoma. Follicular lymphoma. So it's also very common in adults. Typically affects adults and not children. The most important thing about this one is it's indolent. When meaning indolent is the least aggressive of the non-Hodgkin lymphomas. So as described here, the painless waxing and waning lymphadenopathy. So you see single large lymph node in the patient. Maybe brain came for a bacterial infection, and then you thought the question was say, okay, you thought it was the lymph node, the lymphadenopathy was a result of that infection, but then you've treated the infection and lymph node persists, and that lymph node can remain there for years. So, and it just varies slightly in size and shape, but it's persistent. The patient doesn't have really any other symptoms, just that enlarged lymph node. So when the patient who you just see enlarged lymph node, right, particularly the cervical area lymph nodes or even the axillary lymph nodes. So if you just see that enlarged and it's persistent, it remains there. It doesn't go. It won't go away. It will just very slightly in size and shape. That's why I talk about the waxing and waning. But and it's not spreading. It's not doing anything. The patient doesn't have any other symptoms. It's just that lymph node that's there, right? So it's the least aggressive of them. That's why I talk about the indolent cause. Now, the next thing, so that's the two. The other next important thing is this translocation. So you're beginning to notice that the molecular for this non-Hodgkin's, this molecular aberration is very important for you to remember. So we said Burkitt's was 814 with overexpression of CMYC. Here you have 1418. All right. So translocation between chromosome 14 and 18. All right. Translocation between chromosome 14 and 18. And what's the significance of this translocation? Overexpression of BCL2. So remember, it also talked about BCL2 in diffuse large B-cell lymphoma. It's also an like I said before, it's a proto-oncogene, anti-apoptotic, right? As I said here, inhibits apoptosis. Very, very important. Very, very important for you to remember this. So follicular, the least aggressive of the non-Hodgkins, all right? Affects mostly adults, not seeing it in children, mostly affects adults, uh, waxes and wanes with peripheral painless lymphadenopathy, translocation between 14 and 18, and last one over with resultant overexpression of BCL2, which is an anti-apoptotic protein and protects the tumor cells from apoptosis or cell death by apoptosis. Okay, so moving on to mantle cell. Mantle cell lymphoma. So this one is much more common in males, adult males compared to females. And then when they talk about mantle cell, or this phrase mantle, what do they mean by that mantle? So like we were talking earlier about the lymph node structure. So if you see remember we said the lymph node, we talked about the cortex and the medullary sign, and then for the cortex is the paracortex, and then there are the lymphoid follicles. And then for the lymphoid follicles, say there's the primary and the secondary. Now, these follicles, all right, they have several layers to it. So for secondary follicle, for example, the innermost part of it is called the germinal center. Okay. The innermost part is called the germinal center. So if we're going to, I'm trying to explain because that's where the name mantle cell comes from when they're talking about mantle cells. So this is a follicle. All of this is a follicle. All right. We discussed this in the lymphoid structure for immunology. So this is the follicle, and then this part is secondary follicle because this is your germinal center here. All right. This is germinal center, the pale center. Okay. And then we said that this is where your B cells that have been stimulated will go there and undergo somatic hypermutation and isotype switching to start producing immunoglobulin G and the other types of besides immunoglobulin M. Then around this germinal center, you have this area here. So this is your mantle. This is the mantle zone. All right, this is the mantle zone. So when the B cell becomes stimulated here, so when your B cells come to the lymph node, remember when we said the secondary lymphoid organs like the spleen, the lymph nodes, that your battle station where the B and T cells go there to encounter an antigen. So when they come, the B cells, the naive B cells, the ones that have not encountered any antigen, they come and they stay here. So when they encounter the antigen and they are stimulated, then they go down here, all right, and then start undergo the somatic mutation, hypermutation, and isotype switching to start producing your IgGs and IgA and IgE. So this is the mantle. So when they say the mantle cell lymphoma, they're talking of this area here. So the mantle around the germinal center. Okay. So that's where the name mantle cell lymphoma comes. So it's around it's in the lymphoid follicles, but the one that surrounds the layer that surrounds the germinal center. All right. So what's the next thing about it? Very aggressive. Okay. So let me use a different color for this. So it's very aggressive. Okay. So very aggressive. And because of that, because of its aggressive nature, patients typically are present in the late stage and there's not much treatment for it. There's not much to do to treat it because there's the treatment, most treatments against it are unsuccessful because of its aggressive nature. So that's one thing. The next thing you need to remember is the translocation again. All right. So said buckets 814, follicular 1418, mantle cell 1114. All right. 1114. Why am I emphasizing it? Because they can give you a question of a patient and then tell you, okay, besides the symptoms, the lymphadenopathy and all of that, further testing revealed that okay, this tumor has translocation between 814, 1418, 1114. Sometimes you just mention that you know, okay, this is what they are talking about, and then you take the answer and you move on. All right. So, and what does this lead to? By expression of cyclin D, cyclin D one. This cyclin D1 is very important when you come to cell cycle regulation. It's one of the factors that regulate the cell cycle, right? So I've talked about this. I've given another session on cell cycle. I think maybe I'll post that in the group, by the group Telegram group. But I talked about the cell cycle, and part of the regulators of the cell cycle, we have the cyclin, which bind to cyclin-dependent kinases, right? We have the tumor suppressor genes, right? Cyclin-dependent kinases, and tumor suppressor gene. So as you can see, cyclin D1 is the cyclin. It will bind to CDK. And what they do, they help the cell to move through parts of phases of the cell cycle, right? So if you talk about phases of the cell cycle, if you talk about phases of the cell cycle, that's you have the G1, okay? G1, you have the S, the G2, and then the M. And you remember we said there are restriction points. So there's a restriction point between G1 and S, and then between G2 and M. So those cyclin-dependent kinases help the cell to traverse these checkpoints. Because if the cell can't pass those checkpoints, then it will not be able to divide and multiply. That's the whole essence of cell cycles, to divide and multiply. So this cyclin dependent kinases will help the cell to keep dividing continuously. All right. So that's the essence of that cyclin D1. Okay. So now next thing is marginal zone lymphoma. So marginal zone is still another part of the lymphoid follicles. All right. So if the mantle zone or mantle cell area, if you say this is the mantle area, the marginal zone is the most peripheral area of it. All right. So the mantle zone will be this, the fringe, the areas mostly at the fringe here. All right. So that will be your mantle zone. So that's mantle zone lymphoma. Right. So of course, the most important thing about mantle zone that I want to remember is that it's associated with chronic inflammation. Chronic inflammation. Okay. So mantle zone lymphomas, or sorry, marginal zone, I'm saying mantle zone. Marginal zone lymphomas, chronic inflammation. So remember we talked about autoimmune disorders. This is where they come in, right? So the Hashimoto thyroiditis, the Jorgen syndrome. Remember I said Hashimoto thyroiditis, all right? Hashimoto thyroiditis typically involves the thyroid gland, where you have the anti-thyroid peroxidase antibodies, for example, and you in within the thyroid, the lymphocytes have invaded the thyroid and are destroying the thyroid. For Jorgen syndrome, you have it affecting the tear gland and the lacrimal glands. All right, the tear glands, the lacrimal glands, and so if this inflammation goes on for a long period of time, it can lead to your marginal zone lymphoma arising in the thyroid gland, or the salivary gland in Jorgen syndrome, or the tear gland in 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 the tear gland and salivary gland in Jorgen syndrome. All right. So those are some of the autoimmune conditions that can be transformed into marginal zone lymphoma. The other thing is this chronic gastritis. So remember, chronic gastritis typically caused by H. pylori. So the other, remember, we mentioned the other pathogens. We talked of hepatitis, HIV, talked of Epstein-Barr, HTLV. Now another oncogenic pathogen. So this is an oncogenic pathogen, okay, that can cause a malignancy. That's non-Hodgkin lymphoma, specifically the marginal zone lymphoma, H. pylori. All right. So in cases of chronic gastritis, and because it's involving the mucosal tissue, that's why they call it a multoma. So this malt lymphoma. The other short form is multoma. So that's mucosa associated. Malt stands for mucosa associated lymphoid tissue. So this is example your Peyer's patches, for example. All right. But most of the GI tract has lymphoid tissue in it. So if that tissue if the lymphocytes there in that GIT gets involved in chronic inflammatory conditions, like in PUD, peptic or chronic gastritis, which is caused by H. pylori, that can lead to non-Hodgkin lymphoma, particularly the marginal zone lymphoma. And the good thing about it is that this lymphoma can regress when you eradicate the H. pylori using your triple or quadruple therapy, right? Your triple or quadruple therapy. So to eradicate the the um, the H. pylori. So the most important thing of marginal zone is type of lymphoma that arises in areas, tissues that are involved with chronic inflammation, whether autoimmune disorder or infectious pathogen. The most important here, H. pylori, right? Autoimmune conditions, Hashimoto thyroiditis, Jorgen syndrome. So very important to remember. Okay, so moving on, the next thing we'll talk about is um, the primary CNS lymphoma. Primary CNS lymphoma. So this one associated with Epstein-Barr virus, but also it's AIDS-defining illness. AIDS-defining illness. So when you get to microbiology, you need to know what are the AIDS-defining illness. But primary CNS lymphoma is one of them. All right. So typically occurs in immunosuppression caused by HIV AIDS, particularly AIDS specifically. And the Epstein-Barr virus is associated with this condition. So two viruses, HIV and Epstein-Barr, all right, that are associated with this condition, primary CNS lymphoma, which is an AIDS-defining illness. And how does it present? Confusion, memory loss, seizures. Okay, and you see when you do CT scan, you see a mass, particularly a single ring enhancing lesion. Now you need what's the another condition that can simulate this cerebral toxoplasmosis, right? Cerebral toxin can also cause the confusion, memory loss, seizures, and also an infection that occurs in people who are immunosuppressed, like HIV. So you need to, before you treat, you need to do a CT scan because the treatment for you can, if it's toxoplasmosis, you can treat it. You know, we said toxoplasmosis is a protozoan, all right, caused by Toxoplasma gondii, and part of the treatment for it, pyrimethamine, sulfadiazine, which you can use to treat that, right? So look at, so when you talk of the ring enhancing lesion in in primary CNS lymphoma, so this is it. When you say ring enhancing, this is what they mean. Okay, you can see the ring. So it's like a ring that's well enhanced. You can see it is very, it's well demarcated from the rest of the brain tissue. That's why they say ring enhancing lesion. Now, for primary CNS lymphoma, it's usually a single or singular lesion. All right. But then when you talk of toxoplasmosis, you see it's scattered everywhere. Multiple ring enhancing lesions. Multiple ring enhancing lesions. So this is one. So you can see there are multiple in the brain here. So this is one. Okay. So you can see there are multiple. So that's what will help you differentiate it from primary CNS lymphoma, which they both have the similar presentation, but the treatment is different, right? If you talk about cerebral toxoplasmosis, treated with pyrimethamine, sulfadiazine, of course, very important for you to remember mechanism of action of those drugs as well. So that's the the main difference, the differential diagnosis of primary CNS lymphoma. All right, so said two viruses for primary CNS lymphoma, Epstein-Barr, HIV, and it's a age-defining illness and has a similar presentation with cerebral toxoplasmosis, as confusion, memory loss, seizures, and all of that, and typically presents as a single ring-enhancing lesion on MRI, right? While toxoplasmosis, cerebral toxoplasmosis, multiple ring-enhancing lesions in the brain. Okay, so done with B cells, non-Hodgkin lymphomas from the B cell. Now moving on to non-Hodgkin lymphomas involving the T cells. So when I say T cells, particularly your CD4 positive T cell, right? CD4 positive T cell or helper T cell. Right. So for those of your step one, there are just two of them. There, of course, there are more, but to step one, there are just two that you need to focus on. Okay. So we have the adult T cell lymphoma, which occurs. So both of these conditions arise in adults. And for the adult T cell lymphoma, the human T cell lymphotropic virus, the human T cell lymphotropic virus. Now, this virus is very similar to what? HIV. They're in the same class, right? They're in the same class. They exhibit tropism for what? When I say tropism, the cell they infect is CD4 T cell. HIV also infects CD4 T cell. This one also infects CD4 T cell. They are both retroviruses. So this virus also has retro reverse transcriptase. They are both enveloped. They have the single-stranded RNA, which is a positive sense single-stranded RNA. The other thing is the HTLV also has a similar mode of transmission as HIV, both vertical and horizontal. When I say vertical, mother to child, horizontal, talking of sexual as well as blood use of blood transfusion IV drug use, and all of that. Okay, so similar mode of transmission as HIV. All right. So how does it present? So Tuga involves people from Far East Asia. That's the talk of Japan, West Africa, and the Caribbeans. So you could get a history of that. Say somebody from Middle East, from Japan, okay, went to visit there or spent some time there, then came back and then started presenting with cutaneous lesions, skin lesions, and then lytic bone lesions. And when you do the blood work, you see hypercalcemia. All right. So very, very important for that you to remember. So cutaneous lesion, and in addition to that, lytic bone lesion with hypercalcemia, so elevated calcium levels. So those are the main features to remember about it. So the next one we'll be talking about is the cutaneous T cell lymphoma. So cutaneous T cell, the other name for this is mycosis. Means a difference. So the other name for this is called mycosis fungoides. Okay, that's the other name they call it, mycosis fungoides. So here you have the T cells. The abnormal T cells. They go into the skin. They go into the skin, and that's what causes all these plaques and nodules you're seeing in this patient. So you see, uh, it will cause patch, plaques, and nodules, as you can see here. So it's the malignant T cells invading into the epidermis and the dermis of the skin. And then another feature that they will use to describe these malignant cells in your test, they'll talk about that the nuclei of these T cells, they appear cerebriform. They have a cerebriform nuclei, meaning the nuclei has multiple convolutions. All right. So they talk about T cells or abnormal T cells that have cerebriform nuclei. That's a very important term. They can talk about, mention that in the test, in your in your in the vignette. So when you have cerebriform nuclei, T cells, patches and plaque, okay, uh, think about cutaneous T cell lymphoma. Okay, cutaneous T cell lymphoma. So you can see this one forms nodules as well as multiple patches on the skin and plaques as well. Right. So that's one thing. So let me show you what they mean when they say the cerebriform is very convoluted. Uh, so that's this is the cell. So this is the nuclei of the cell. Okay, this is the nucleus of the cell. So you can see it's very convoluted. So that's why you call it cerebriform nuclei. Okay, cerebriform nuclei. So when you hear that term cerebriform nuclei, they are talking about uh, mycosis fungoides. Okay, mycosis fungoides. This is another image. You can see how it's very convoluted. All right, and then of course these T cells, once they're done with the skin, they can spread into the bloodstream and go to different organs. They can go into the bloodstream and spread to different organs. But the most important thing about this mycosis fungoides is it involves the skin. And then, yes, so once it spreads to the bloodstream, can go to the lymph node and other abdominal visceral organs. Now that there's a version of that disease that has a different name. We don't need to bother you. But the most thing when you hear they're talking about mycosis fungoides, it's just the T cells involving the skin only. T cells involving the skin only, which causes these plaques, right, and patches. And they describe the T cells as having a cerebriform nuclei. Cerebriform nuclei. From the skin, they can spread to other organs, to other internal organs, lymph node, viscera, and then once they can also get into the blood, which you've seen a blood film of that. So they can. So once they show you a blood film of that, and then they tell you a patient has plaques and now patches, nodules, and they say or they describe the nuclei as cerebriform, you're talking of cutaneous T cell lymphomas. All right. The most important common version is variant of it, mycosis fungoides. That's what you're seeing here, mycosis fungoides. There's a variant of it that spreads from the skin to other different organs, which they didn't talk about here, so I'll not mention that. Okay, so I think we are done with the session